Good morning, everyone. So we'll go to lipid management in diabetes is my next talk. And I will break it into parts. First of all, we start with the good news, because we always start with bad news when we're talking about diabetes prevalence. And we'll show how important lipids are in the contribution of cardiovascular disease. We'll talk about pathophysiology and therapeutic options, looking at the pathway of the development of cardiovascular disease due to lipids. And we'll see what the guidelines are suggesting we achieve or we aim to achieve. We'll see also lifestyle modification and lipid-lowering agents' impact on cardiovascular disease. So the good news is this. This is data from Harding and colleagues published in 2019, an extensive review of current evidence on the global trends in diabetes complications. And I'd like to show 2 points on this slide. One is that there were countries with high prevalence of complications, and they have done interventions in those countries to actually reduce the complication rates. And you can see in the graph here, at the top is Denmark, and followed by Finland in men, and Finland in females in yellow. And then you can see in green is the UK. So for 2 decades, there has been an average drop in complication rates of around 32%. So point 1, even if there are high prevalence of complications, we can do something about that to reduce the complication rate in our patients. And the second one is that there are countries where they've managed to keep their complication rates low by prioritizing public health management strategies, including diabetes. And you can see Sweden right at the bottom there with the lowest rate of diabetes complication rate. So all these things can be done. I know it's difficult if there are resource issues, but given the right policies, I think these are achievable. But the other good news is, actually, this is something you probably wouldn't be expecting, that the life expectancy is projected to be going up across the world from 2016 to 2040. I mean, there are bouts of disasters that come around, but generally our life expectancy is going up. And even in the low-income countries, there's improvements of life expectancy towards the age of 60. Anyway, why are lipids important? And I think this data is already well known to yourselves. This is data going back to 1993, where they screened 350,000 men aged between 35 and 57 between 1973 to 1975 in the US. Just over 5,000 had type 2 diabetes, and they followed them up over the next 12 years. And you can see here, as the plasma concentration of cholesterol went up, so did the prevalence of cardiovascular deaths in the population. It was much higher when the patients had type 2 diabetes. So most of us in this room approach lipid management in a staged fashion. Firstly, we have to measure the lipid fractions. And a lot of laboratories now give us triglycerides, LDL cholesterol, HDL cholesterol. And then some laboratories will give us the rest of the fractions. But the recommendations now is that we should also be measuring ApoB. Because ApoB, like cholesterol, has been shown to steeply increase risk of cardiovascular disease. The next stage is to address lifestyle modifications, and you can see if we address weight reduction through diet, physical activity and reduction in alcohol consumption will actually reduce levels of low LDL and triglycerides between 5 and 10% and push the levels of HDL up between 5 to 10% as well. So lifestyle modification does improve. Now, there was some interest in surgical management as far back as the 1990s. And this is a study, not reproduced, from the Minnesota, US, where they picked patients who had had a myocardial infarction between 1973 to 1983. So they took 800 of these patients and randomized them into diet and partial ileal bypass surgery. And you can see this was only indication to lower cholesterol, and that was achieved in around 23% of the surgical group compared to the group that had diet alone. You can see HDL was higher in the intervention group of 4.3%, and unfortunately there was no overall differences in mortality rate. But when they analyzed a subgroup of patients who had ejection fraction of more than 50%, they noticed that the death rate from the group that had surgery was 35% lower. Now, obviously we don't do this anymore, except in those patients with diabetes and obesity, and the surgical management is purely for the obesity. But nevertheless, when you do that, you will also see a reduction in cholesterol levels. Now, we've had many opportunities to target these pathway from the mechanism of lipids associated endothelial dysfunction. Chronic hyperglycemia and hyperlipidemia causes enhanced oxidation stress, increasing the oxidative LDL formation, activation of the immune system, and upregulation of cytokine production. And this leads to the formation of foam cells. As you know, foam cells undergo apoptosis, and in combination with the accumulation of cholesterol, this can lead to formation of atherosclerotic lesions, which are prone to rupture. It's when the rupture of the plaque happens that we get a cardiovascular event. And all the drugs that we are using are in the pathway to production of endothelial dysfunction, as you can see on this cartoon. But to summarize, this is probably shown better on this slide, which suggests that firstly, we have to reduce intestinal cholesterol absorption, and this is done by ileal bypass surgery, as described earlier, or when it's being done for obesity patients. The resins and ezetimibe do the same, and they also increase conversion of hepatic cholesterol to bile acids. Then we got the statins that reduce cholesterol pool by reduction of cholesterol synthesis, and then the PCSK9 inhibitors that upregulate LDL receptors to increase LDL clearance and therefore lowering plasma cholesterol. So what we do when these drugs are failing, we have to then look at others options, and here's a study using fish oil, icosapent ethyl, which was published in 2019. It was a multi-center randomized double-blind placebo-controlled trial taking patients with diabetes and established cardiovascular disease or other risk factors who had triglyceride levels between 150 and 490, and they gave them 2 to 4 grams of icosapent ethyl compared to placebo, and followed up the patients over 4.9 years. And you can see the hazard ratio for cardiovascular primary endpoints was significant in the intervention group. So fish oil is something else we can add. Fibrates, of course, are the other group of agents that we can use. And there are always those patients whose dyslipidemia is still a problem despite maximum use of statins, that we can consider fibrates. Although National Institute of Clinical Excellence in 2014 were not in favor with that approach, but most of us in this room will give patients fibrates if they're still having problems with dyslipidemia. And of course, some of the patients who have been intolerant to statins, and certainly those with familial hypercholesterolemia, it's almost impossible to get to normal levels of cholesterol without the addition of fibrates. And in the future, of course, we have to deal with this unmet need in managing dyslipidemia that is increasing globally. And there are some products on the market that have already been used in phase 3 trials, including pimafibrate, vupanersen, and velanesorsen, and of course inclisiran, a small interfering RNA targeting hepatic PCSK9 synthesis. And then there's also the PCSK9 inhibitor called evolocumab, which still needs to find its way to diabetes patients. Nicotinic acid is an old agent with very high side effects, but nevertheless very effective in pushing HDL cholesterol between 10 and 35%, and reduction of triglycerides 20 to 30%, and very effective for LDL cholesterol, 10 to 25% reduction. But of course, also attractive for the use of niacin is the fact that it can also reduce LPA levels by 20 to 30%. So I mentioned the protein converters subtisylin kexin type 9 inhibitors, and these agents are very good at dropping cholesterol levels, as shown in this slide. ApoB 32 to 53%, non-HDL cholesterol 37 to 52% reduction, LPA 17 to 39%, triglycerides reduced to 6 to 26%, and the increase in HDL-C of 6 to 9%. So very effective. As you know, this is a protein produced by hepatocytes, which binds the LDL receptor and prevents recycling, and therefore reduces LDL cholesterol uptake. This is the data published recently from the Odyssey trials using alirocumab, 75 to 150 milligrams IV, compared to usual care in patients who had received maximum statin treatment. And you can see significant reduction in non-HDL-C below 100 in 37.9% who had alirocumab, and 6.7% in usual care. Similarly, reductions in LDL cholesterol and ApoB to less than 80 in the intervention group. So what do we do then to make a difference? Obviously, the guidelines are suggesting we should be achieving LDL cholesterol levels of about 70 milligrams per deciliter in these patients who are at risk of further CVD recurrence in the future. And those diabetes patients with one risk factor should also achieve less than 70 milligrams per deciliter. And ApoB, as I mentioned before, should be aiming for less than 80 milligrams in diabetes patients with one risk factor or with a cardiovascular event. The high-intensity statin therapy is shown here. So atorvastatin, about 10 to 20 milligrams, is moderate intensive therapy. and will reach targets of 30 to 50% reduction of LDL cholesterol, and then the high intensity for the high-risk patients groups can achieve LDL cholesterol reduction of more than 50%. And the recommendations is that for primary prevention, we should be using these risk calculations. So all the patients who have risk factors that takes them to the red area zones should also be offered high-intensity treatment. So it is very clear that the best approach is looking at multiple risk factor treated to target, and this is data showing the impact on lifestyle modification compared to usual care, and this one is showing the impact of those patients with diabetic kidney disease who were treated to target and also offered cholesterol reduction using statins. And if you can see there, the separation of the trials of conventional therapy compared to intensive therapy was very significant. So there is some controversies that lowering cholesterol too low may cause hemorrhagic stroke, but I think there is benefit in terms of things like recurrence of stroke has shown that actually it is actually quite safe for us to go to lower levels of LDL cholesterol. This is quickly a case study of ours who presented to the GP in 2001 with type 2 diabetes. I think they missed the fact that the levels of cholesterol and triglycerides was most likely that this patient also had familial hypercholesteremia, which we picked up from our clinic in the metabolic clinic. And by the time they got to us, we had to use rosuvastatin, aloquimab, and to achieve levels of cholesterol to 177, HDL cholesterol, triglycerides of 119, and LDL cholesterol of 131 by using several combinations of lipid lowering agents. So in conclusion, diabetes remains a major public health concern. Dyslipidemia in particularly raised low-density lipoprotein cholesterol and triglyceride levels, and high-density lipoprotein cholesterol are associated with increased risk of cardiovascular disease. Lifestyle modification and tackling risk factors is cornerstone for reducing cardiovascular complications. Lipid management has significant impact on reducing cardiovascular events. So we need to be targeting all these fractions and measure them if we can to monitor our patients so that they can reach the target. Statin therapy is recommended as primary pharmacological agent to achieve target LDL cholesterol for the goals. Statin decrease plasma LDL in dose-dependent fashion between 20 and 55%, and in some patients there's a need to combine with other lipid-lowering agents to achieve the targets that we are aspiring. So on that note, Mr. Chairperson, I will end there and thank you for your attention.